This seminar is for educational purposes only. It is not a substitute for professional medical advice or treatment. Consult with your medical provider for medical advice or treatment. Although the presenters try to keep the information in this seminar as accurate and timely as possible, the speakers and Mather Hospital assume no duty to ensure the seminar is error-free. The speakers and Mather Hospital are not responsible or liable for any claim, loss, or damage resulting from you viewing this seminar.
Good afternoon. On behalf of the JTM Foundation and John T. Mather Legacy Society, welcome to today's HealthyU webinar. My name is Eric Churches and I'm a member of the JTM Foundation Board of Directors. The JTM Foundation's mission is to foster relationships with those individuals and organizations who have a like-minded vision and the desire to support exceptional healthcare at Mather Hospital for the benefit of our community. Every donation to JTM Foundation solely benefits Mather Hospital, its programs, and growth initiatives. Mather Hospital was founded on December 29th, 1929, with a significant legacy gift from John T. Mather in his will. He was a famous shipbuilder within the village of Port Jefferson, and it was the first hospital in the town of Brookhaven to provide highest quality, innovative, and compassionate healthcare for everyone in the community. Through planned gifts, members of the Legacy Society act as stewards for Mather's vision and ensure that the community will have continued access for generations to come to a upstanding, fine, excellent hospital. If anyone would like more information regarding the JTM Foundation or the John T. Mather Legacy Society, please contact the Director of Charitable Giving, Carson Nicholas, at 631-426-2723. Our presenter today is Dr. Raj Goyal, Director of the Electrophysiology Lab at Mather Hospital. Dr. Goyal practices with Three Village Cardiology in Port Jefferson and with Northwell Health Physician Partners at Bayshore. He is an assistant professor at the Donald and Barbara Zucker School of Medicine at Hofstra Northwell. He received his medical degree from SUNY Upstate Medical University in Syracuse, New York, and he did his residency in internal medicine at Boston University Medical Center. Dr. Goyal completed a fellowship in cardiovascular medicine at Stony Brook University Hospital, where he also served as chief fellow. He completed his advanced fellowship in clinical cardiac electrophysiology at New York Presbyterian Weill Cornell Medical Center. He is a fellow of the American College of Cardiology and Heart Rhythm Society. And with no further ado, here's Dr. Goyal.
Thank you, Eric, for that introduction. Let me just share my screen here. Okay. Thank you all for joining on today's call and today's webinar. My name's Dr. Rajat Goyal. I'm a clinical cardiac electrophysiologist. I totally understand how that can be a mouthful, but I'd like to use this time to explain to you what it is that I do, how I'm able to help patients, and what kind of advanced care we are now providing at Mather Hospital. So I think the thing that many people ask to start with is, what is cardiac electrophysiology? It sounds very fancy, but think of us as cardiologists that focus on arrhythmia disorders. As you know, our cardiac catheterization lab opened last year, and that is, I like to think of the heart as having electrical and plumbing. So whereas Dr. Gruberg focuses on the plumbing, which is the cardiac catheterization lab and making sure that our arteries are open, I'm more of the electrician in-house. So what is it that I actually treat? And really it boils down to two basic entities. Either your heart is going too slow which is called bradyarrhythmias, or it's going too fast, which are tachyarrhythmias. And I felt that really the best way to get an idea of what we treat is really to go over cases and ways we've been able to help people. So I'd like to warn you that throughout my talk, I'm going to be showing you EKGs and X-rays, and I don't want you to feel overwhelmed thinking that I'm going to put you on the spot asking you to read any of these, but more as an understanding to see how our interventions can help patients. So we'll start with our first case. It's a 74-year-old woman. She has high blood pressure and diabetes, and she presented to the hospital with difficulty breathing and dizziness and lightheadedness. We performed an EKG, and what we saw in the EKG was that her heart rate was very, very slow. This is a typical EKG. As you can see, the EKG strip lasts about 10 seconds. So if we are to count each one of these large deflections on the EKG, that represents the heart beating. So in 10 seconds, the heart beats 5 times. And we know 60 seconds in a minute, so 5 times 6 is 30 beats per minute. So her heart rate is going very, very slow. And if we look closer, the EKG tells us that actually the top of the heart is beating, but none of those signals are making it to the bottom of the heart. So they're kind of working separate to each other. So to bridge that gap, so this is called complete heart block. And the only treatment is a pacemaker implant. So when we perform pacemaker implants, we're able to do this minimally invasively using X-rays. So here is a video of what what the pacemaker looks like on X-ray. So, oh, sorry, go back. So you can see that there are 2 wires. This is the shadow of the heart on the sides, and there are 2 wires in the heart. One is going to the top, and one is going to the bottom. And the top and the reason we have 2 wires is so that the information from the top can be communicated via the pacemaker to the wire on the bottom so that electrical impulses can be delivered to the heart, allowing it to beat. And if we want to take a quick look at the implant process, you can see over here on the top right of the screen that we have an instrument there. So that's actually where we make our incision. And through that incision, we can access our veins. And as we know, with the veins and the arteries, if we follow them down, all roads are going to lead to the heart. So we're able to take our wires and bring equipment into the heart. So in this video, the operator is using a lead and positioning it into the ventricle or into the bottom of the heart. After they do that, they can move on to position the second lead in the top of the heart. Once everything is placed, they connect the leads to a pacemaker, and then they tuck it underneath the skin. And this is and I mentioned over there that it was his bundle pacing, but we'll come back to that. So our patient, she got her 2 wires, they connected it to the pacemaker, and this was her EKG before, again, the heart rate of 30 beats per minute. And now, after pacemaker implant, her heart is beating a lot faster, her symptoms resolved, and she felt a lot better. And this, the first time we see this, it looks very interesting. But now we've become so good at this, it's become almost routine, to the point that we have, researchers have looked into seeing how can we be even better at performing pacemakers. So this is a diagram of the heart, and I'm pointing, the arrow's pointing to where we usually put our pacemaker leads, especially for the bottom of the heart. As you can see, we put it right in the muscle, pretty much at the tip of the heart. But the interesting thing about the heart is that although it's a pump that's electrically active, it actually has a system of communication systems built in that allows information to be distributed super quickly through to the entire heart. And that's represented here by these yellow, excuse me, by these by the yellow strings, almost they look like. These are called the His-Purkinje system. So you can see the yellow goes here to the bottom of the heart, and then it spreads out throughout both left and right sides of the heart. And think of this as, think of this as your broadband. It's delivering information super, super quickly. Whereas when we pace the heart, the muscle itself can actually talk to its neighbor and get information that way. So this is how traditionally we've been pacing. We pace the muscle and we allow the muscle to talk to each other slowly to get information across. But the thought was, well, what if we can actually use our innate conduction system so that we can utilize this conduction superhighway, this effective means of transferring information so that the right and left sides of our heart can beat together and beat more efficiently. So we thought about actually pacing in these areas, and we've come to this new realm of pacing called conduction system pacing, which is very exciting for us. So this is a separate patient of mine that here you can see that their heart is, doing okay, but he was at times having episodes of very, very slow heart rate. Here it doesn't look like it's that slow, but we implanted a pacemaker. And after the pacemaker implant, you can see that these large deflections have become more narrow. And every time we see more narrowing, that suggests that information is being delivered more effectively and being delivered at the same time. And so we're we're engaging that conduction system and allowing the heart to beat more efficiently. So you can see the differences in the location of our pacing wires, and it might be a little hard to see, but here on the bottom wire, we have it all the way at the tip of the heart, kind of a stable location where we're pacing the muscle. Whereas in this patient, it's a little bit pulled back, and it's actually, the goal is to engage that conduction system. And when you look at these EKGs side to side, you can see how when you pace the muscle on the left, the deflections are wider, whereas if you look at the pacing deflections on the right, they're much more narrow. So we're able to deliver a better quality of pacing. And this has been a large, big advancement in our field, and we're continuing to do more research on this. And it's great that it's no longer something that you think of only research centers. We're even doing this. We will be doing this at Mather Hospital as well. So I'm going to shift gears a little bit. So this is another patient with a very slow heartbeat. So it's an 80-year-old male, again, high blood pressure. He has heart disease with stents, and he has an arrhythmia called atrial fibrillation, which we will discuss later on in the talk. And he came in with fatigue, and he had a slow heart rate. His heart rate was 42 beats per minute based on this EKG. So in this patient, who's older, who only needs pacing from the bottom chamber of the heart, we decided to offer him a novel technology called the leadless pacemaker. So a leadless pacemaker, I like to think of it as a capsule that we implant inside the heart. This little capsule has all the machinery that's needed to make the pacemaker function. It also has the battery built in. There's no recharging necessary. And if implanted, in a effective manner, these pacemakers can last about 8 to 10 years in some cases. So as you can notice, because it's a capsule, there's no wires anywhere. So you don't even need that pacemaker box that you see, on your chest that you may need in a traditional pacemaker system. Obviously, cosmetically, that's appealing, but the other advantage is that Wires over time can heal into the heart, they can scar, they can get infected. So by pursuing this leadless option, we're actually able to limit long-term complications from pacemaker implants. The way we implant this pacemaker is we actually implant it from the groin. So again, it's minimally invasive. There's no open heart surgery here. We use X-rays to position our catheter in the right location. So on this X-ray image, I've highlighted where the right ventricle, the right side of the heart, and the left side of the heart is. So the heart's kind of like a football, and what we're doing right now is we're looking at the tip of the football back, so it's going to look kind of circular. So that's why we have the circular left ventricle, and the right ventricle kind of hugs the right ventricle hugs the left ventricle. And that's where we have our catheter pushed right on the wall between the two chambers. It's called the interventricular septum, or the septum for short. So after we position our device there, we'll shoot a little bit of contrast dye just to confirm that we are in the right location. And then we'll check in another view. We'll take that football and we'll, instead of going from the tip, we'll turn it on its side. And so we can see the tip and the back. And that's what we're seeing over here. This is the ventricle, or the bottom of the heart, and this is the atrium, or the top of the heart. And you can see how our device is seated a little bit further in. And we again make sure it's positioned properly. Once it's positioned properly, I don't know if you were able to see, but there are hooks at the tip of the device. So the hooks latch into the tissue, and then we tug on it to make sure that it's stuck. And we're able to see, it might be a little bit hard because it's not projecting as well, but you can see that these tines, the hooks, they will open a little bit, and that will confirm that we're adequately fixated. After we're done on the X-ray, you can see that all that's required for the pacemaker is right over here. There's no wires, there's no generator, and it's a great solution for our patients. And now you can see the heart rate's a lot better, it's a lot more steady, and better to avoid long-term complications. So we've been talking about pacemakers, but what the other side of devices is defibrillators. And people often wonder, what's the difference between a pacemaker and a defibrillator? And I like to think of a defibrillator in most scenarios like a super pacemaker. So this is a patient of ours. He's 58. He underwent bypass surgery, and his bypass surgery was complicated by a weak heart, or as we like to call cardiomyopathy. And he was referred to us to consider implantation of a defibrillator. So, let's start with, what is a defibrillator? What is defibrillation? So I'm sure you see on TV many times that, oh my God, someone collapsed. We need to rush in, on ER, they'll come in with the paddles and they'll shock. So really what we're doing when we shock the heart or defibrillating is we're resetting the heart. So it's a heart that's actually beating really fast that we're shocking, rather than a heart that has completely stopped. If a heart has completely stopped, shocking actually doesn't help. But what we're trying to do is take a heart that's quivering and resetting it so that it beats normally. And as we had discussed earlier, each one of these deflections represents one beat of a heart. And you can see that once we get to the middle and the bottom strips, that there are a whole bunch of those deflections. And they're very chaotic, they're not regular. So this represents the heart effectively quivering. And when the heart beats so fast like this, there's no blood moving to the brain. And if the brain doesn't have oxygen, you'll collapse. So then it's important for someone to come by recognize that this is happening and deliver high voltage energy to reset all the cells, which you can see as this black mark indicates, that's a defibrillator shock. And after we reset the cells, they go back into beating in normal rhythm. So effectively, think of a defibrillator as your own Dr. House living, through many different mechanisms and, algorithms, reading your heart and identifying when you're in a cardiac arrest or cardiac arrhythmia and delivering this high voltage shock at a time that you need it. What we have found through research is that patients that have weak hearts and cardiomyopathy, depending on what other conditions they have, are going to be at higher risk for developing cardiac arrest. And so we can implant a defibrillator prophylactically, so that should they develop cardiac arrest, they have a safety net that can shock their heart and save their life. And in some cases, even buy them time to get them to the hospital where we can intervene and prevent their heart from having more arrhythmia. So here's an x-ray of a defibrillator. As you can see, it kind of looks really similar to a pacemaker. There's a wire that goes all the way to the tip of the heart. And there's a box over here in the left chest. But you can notice that as opposed to a pacemaker, the defibrillator has an extra coil. And this extra coil allows the delivery of high voltage energy to the generator to effectively shock the heart back to regular rhythm. And these are two views. One is head on and one is from the side, so we know where the defibrillator is going. Now, as you recall, when we were talking about leadless pacemakers, we were talking about how the advantage of a leadless pacemaker is that there are no wires, so there's a lower risk of complications. Similarly, our patient is only 58 years old. It's very young in our line of work, and for them, or in really any line of work, but for a 58-year-old to be living with the wires in their heart for the next 20, 30 years, really poses a potential risk of infection, vascular complications, things that we can potentially avoid. And this thought actually precipitated concerns and research that led to the development of this subcutaneous defibrillator. And, whereas, I'm just going to go back a slide, whereas this defibrillator actually sits inside the heart and can actually pace the heart and bring the heart rate up, this defibrillator actually does not sit inside the heart at all. It sits underneath the tissue, outside the heart. You can see on x-ray, and I cut it off a bit, but the wire is outside the sternum. It's right underneath the skin. And the defibrillator is there. It's your own little safety net, working, analyzing your heart rhythm 24/7. If it sees that your heart is going too fast or possibly going into cardiac arrest, it will intervene and deliver a shock from the coil to the generator. And this has been great for our patients. It really avoids long-term complications of leads, and it also, should they have an infection, it's much easier to manage if there's something outside the body than inside. So we've been talking a lot about the slow end of things and pacemakers and devices. I'd like to talk about the other side of electrophysiology, where we deal with fast heart arrhythmias. So many times we'll have patients that complain of palpitations, or they'll say my heart is racing, and the cause of that can be, there's so many. Some of these we can actually cure, some of them we can't, but we can manage very effectively. So I'd like to talk about a syndrome that's very common called supraventricular tachycardia, or SVT. It happens in all age groups. The fortunate thing is that's completely benign, but it can cause a lot of symptoms. And it's funny because sometimes people will go on their entire lives thinking they have anxiety, and it turns out they don't have anxiety. They have an arrhythmia that's causing their heart to go fast and making them feel unwell. So this is a 36-year-old woman. When I first saw her, she was actually 8 months pregnant and she had palpitations. You can see that there's a lot of these large deflections going on in this EKG. And her heart rate at the time was 150 beats per minute. And so it turned out that she was not, this was not regular rhythm. She was actually having a short circuit in her heart. So we were able to give her some medications. She delivered safely. However, despite medication, she continued to have palpitations. So we talked about a procedure called an ablation. So as you've seen before, we love using x-rays. So when we do an ablation, we put in multiple catheters into the heart to record electrical signals from the different chambers. So you can see again, we have projections in the RAO and LAO projections. It kind of just think about the football. RAO is a football sideways, LAO is a football head-on. So on RAO, we have catheters in the top right chamber, the right atrium. We have catheters in the right ventricle, the bottom chamber on the right side. We have a catheter here in the coronary sinus, which is a vein, is the biggest vein in the heart. It actually just allows us to measure signals on the left side of the heart. And we have a catheter in between the two top chambers, which helps us record conduction through an electrical gate between the top two. And this is another a kind of demonstration of where all the catheters are. And so we're actually able to record electrical signals from within the heart and really spread them out so we can understand what's going on. So on the top, there's that EKG, which we've actually stretched, and below are signals from each of the different chambers in the heart. So you can see right atrium, the His bundle, the coronary sinus, the right ventricle. And it's, it's funny, sometimes I look at this and I feel like I'm in the Matrix, just reading a bunch of signals. And fortunately, all it takes is training and everybody can get there. There's nothing special about me. So we were able to treat the short circuit in her heart, which is called the slow pathway. And afterwards, she had no palpitations and her symptoms completely resolved. This is one of the arrhythmias that we treat often and is actually curative. So it's a great, it's great that we have the capabilities to, do this at Mather and to offer it to so many of our patients. This is a different arrhythmia. This is a 50-year-old patient who has diabetes, smoking, cardiomyopathy, again, a weak heart, and he had this EKG. And on this EKG, you can see the large blips. But one thing perhaps you may or may not have noticed, that in between these large blips, there's a lot of underlying, there's a lot of wavy stuff going on. And it kind of looks like a sawtooth. So when we see this sawtooth pattern, we think of an arrhythmia called atrial flutter. And what happens with atrial flutter is instead of the top of the heart beating normally, it ends up beating really fast to the point where blood doesn't move well and clots can form. And those clots can build up and lead and get dislodged and go to the brain and lead to a stroke. So for this arrhythmia, it's very important that patients be on blood thinners or anticoagulation. The great thing about atrial flutter is that it's another arrhythmia that we can actually cure. So I feel like this is a pretty. I always enjoy showing this map. I created, we in our electrophysiology lab, we're able to use different catheters and special software to create activation maps to show us what the circuit, the activation pattern looks like in the heart. So this is actually from a patient of mine when I was in training. So what we're looking at are the two chambers, or the two top chambers of the heart, the right atrium and the left atrium. And we also have the superior vena cava, which is a vein draining into the right atrium, and the inferior vena cava. And on the left side of the heart, these two are separated by a wall. On the left side of the heart, we also have veins that drain blood from the lungs. And you can see that there's a catheter sitting in our coronary sinus, which is that vein I was talking about to allow us to record signals in the left side of the heart. And then this floating catheter over here is the catheter with which we perform ablation. So you can see that the circuit is spinning around the right side of the heart. And this is basically what atrial flutter is. And of course, over here, we've slowed it down, but in real time, this goes much, much faster, and it prevents the heart from beating normally and can promote clots to form, which can lead to stroke. So what we do is through our ablation catheter, we deliver heat energy, effectively electrocautery, along a site, pretty much along a critical site of that circuit so that we can block the circuit. And after we perform these red ablation lesions over here, the short circuit stopped. And the success rate of cure for this arrhythmia is pretty high. It's over like 90–95%. So when I see this, I will often counsel patients to undergo ablation because it can be curative and we can get them off of blood thinners. That being said, a lot of patients that have atrial flutter, this fixed short circuit arrhythmia, may also have its cousin atrial fibrillation, which we're going to talk about soon. And it's important that we look for that. So now many times you'll go to your doctor, you'll have to wear a Holter monitor, they'll put a patch monitor on. And how long can you wear that? At most, maybe a month. These chips, designed by different companies, including Medtronic, Boston Scientific, and Biotronic, they sit underneath the skin, and their batteries last anywhere from 3 to 5 years, and it gives us a long period of monitoring to allow us to see, hey, have you developed AFib in this time? If you have developed AFib, then maybe you should be back on blood thinners so you don't get a stroke. So we have many adjunctive strategies and therapies to be able to prevent long-term complications from arrhythmia disorders. This is a case that I thought I just think it's pretty cool. It's a patient who had prior open heart surgery, and he actually presented to our sister hospital, South Shore University Hospital, with heart failure and an arrhythmia. So when we did the activation map, again, you can see the circuits. We found that it wasn't that typical atrial flutter that we saw previously. Instead, the circuit, this is looking at the top right chamber of the heart, right? These are the veins, and we're looking at it from the side. And you could see that the signals go up, they wrap around to the bottom, and then they come around, and the whole circuit was sustaining pretty much because of this one little gap in an incision that the cardiac surgeon had made that didn't heal. This view is similar to the view that I had shown you previously, and you could see that it's not that typical roundabout loop that we see previously. So we found this gap, and I put my ablation catheter there. You can see all these blips. As soon as I deliver heat energy, all these blips suddenly stop, and we're back in regular rhythm. And this patient has actually done really well. He did well for about 2–3 years. Only recently did he have a recurrent arrhythmia, which we're going to bring him back to the lab to treat. So finally, let's talk about atrial fibrillation. So this is a 64-year-old patient. She's had high blood pressure, diabetes, and she has AFib, which we've treated, but she continues to be symptomatic. So, what is AFib? So AFib is an arrhythmia in the top of the heart. Instead of the top of the heart beating normally, it just kind of quivers. So similar to atrial flutter, however, with atrial fibrillation, there's no set short circuit that you can go in and completely get rid of it. It's just kind of quivering in the heart everywhere. And that quivering, similar to atrial flutter, prevents blood from moving effectively. And so again, clots can form, and they can go to the brain, leading to a stroke. that's why the most important treatment for atrial fibrillation is being on blood thinners or anticoagulation. Now, with atrial fibrillation, all of the arrhythmia is in the top of the heart, right? And the top of the heart is beating extraordinarily fast, about 300 to 400 beats per minute, and it's sending signals to the bottom of the heart very quickly. Fortunately, as I mentioned before, we have a gate in the middle that helps us filter, but sometimes that can cause the heart to go really fast. So we treat with medications to slow conduction down through this gate. But despite doing that, even by controlling the heart rate, people can often still have symptoms. They'll feel short of breath, they'll feel tired, fatigued. Sometimes people complain of fogginess. So in that case, we can try to actually get them into regular rhythm, get them out of AFib, and get them beating in regularly. You know, AFib for a long time has been tough to treat, and with recent therapies, we've gotten a lot better. And what we know about AFib is that people that, you know, people who don't have AFib, represented by these lines over here, as compared to those that do have AFib, do better long term. Patients with AFib do have some increased risk of death, possibly related to strokes. They have a higher rate of developing weakening heart muscle or heart failure, where the heart is unable to push blood effectively. There's also a risk of dementia, depression, and overall, I've seen it repeatedly, you know, hospitalizations and affected quality of life. The great news is that now we've been able to treat AFib much more effectively and keep people in regular rhythm and actually blunt some of these outcomes. A common strategy is to perform ablation. And there are two kinds of ablation. We already talked about heat energy, that's called radiofrequency ablation. Here is an example where we are looking at the top left chamber of the heart, or the left atrium. And each of these circles represents a vein that's draining blood from the lungs into the left atrium. And what we try to do is try to make these veins electrically silent. So we cauterize the tissue around the veins so that electrical signals can't get in or get out. And the reason we do that is because we found that these pulmonary veins are, you know, a large, they are frequently the sites where AFib will originate. And so these are different ways that we're able to treat it. We've also investigated, and some people use this, some people do cryoballoon ablation, where they actually freeze the area around the veins using a balloon. And that also has been shown to be quite effective. There are new treatment strategies that are coming out, and this one is very exciting in our field. It's called pulsed field ablation. And the reason that it's so exciting is because we're able to almost do this, the pulmonary vein isolation in seconds. So I'm going to orient you all. On the top is the EKG. Over here in this middle, each one of these blips represents an electrical signal inside the pulmonary vein. And the signals over here on the bottom are the signals from the outside of the pulmonary veins, or the left atrium. So what you're going to see is these blips go along, then you're going to see a big shock, and then you're going to see these signals disappear. So the signals are going along, sharp, sharp, and then right here, big shock, and all of a sudden those signals are gone. And this is going to we hope is going to revolutionize the way we treat atrial fibrillation. Our hope is that it will make the procedure even safer than it already is, more effective and more efficient, and possibly even open it up to patients that previously we thought were not candidates. So I'd like to end with one last common scenario we see. So in patients with atrial fibrillation, as we discussed, they are all at increased risk of having a stroke. And so how do we treat strokes? We have to, you know, put them on blood thinners so those clots cannot form. What happens when you have a patient who cannot be on blood thinners because they have a bleeding complication? In our patient here, she had recurrent GI bleeding. What if they had frequent falls? What if they have really, what if they have significant anemia? So for any of these scenarios, we have to think of an alternative strategy to prevent people from developing strokes. So we have a device called the Watchman. So what we do is we go from the groin, as shown before, we puncture across the wall into the left side of the heart. And I'm just going to come back a little bit. So this is our heart, and this is called the left atrial appendage. And the left atrial appendage is an outpouching in the left upper chamber of the heart that has a lot of nooks and crevices, and that's often where many clots are formed, and many of the large clots that cause disabling strokes are formed. So the idea is that we want to plug up this left atrial appendage to prevent patients from having really significant strokes. So as I said, we puncture across the heart, we bring our catheter up, and then we engage the left atrial appendage. As they're zooming out, you can see, look at all the nooks and crannies for clots to form. Once we engage it, we deploy our occlusion device called the Watchman, and over the period of 3 to 6 months, the Watchman heals. And now you have protection from having a very large disabling stroke without having to be on anticoagulation. So, ultimately, we do a lot in electrophysiology. We go from pacemakers and defibrillators all the way to ablations and even procedures like the Watchman. But people often wonder, well, what can we do at Mather? What do we have to do at our sister hospitals? So everything in blue we can do at Mather, which you can see really encompasses a large proportion of what we do. And in the patients where we need a little bit more support, I'm able to bring patients to South Shore University Hospital and do procedures there where we have additional backup of cardiac surgery to make sure our procedures are performed safely. The good thing is that although we are different hospitals, we're all under the Northwell system, and we all work very closely together to provide the best care we can to you. And with that, I'd like to thank you for all your time. If any of you are on Twitter, this is my handle. You could follow me to see some fun, well, it depends on how nerdy you are, but a lot of electrophysiology maps and interesting findings. And I'll take any questions you all have. Thank you.
Dr. Goyle, that was a fantastic presentation. Thank you so much for joining us today. I've learned a lot. I don't know about everybody else. If you do have any questions, please feel free to enter them in the Q&A spot at the bottom of your screen. We'll have a couple of minutes to go over those. Dr. Goyle, how long does a defibrillator last before you replace it? And also similarly, a pacemaker?
It's a good question. So the first thing that I like to point out is that depending on the pacemaker and defibrillator that you have, and this is true for most things, for most of them, we don't change out the wires. The wires stay in place, and because they usually have very good longevity. For the most part, the pacemakers and generators, and defibrillators, their batteries last about 8 to 10 years, and with newer models, that's becoming even longer. I know that some of our pacemakers have projected longevities of about 13 years, and similarly with some of our defibrillators as well.
Okay, great. Can a defibrillator be used for AFib?
So no. Well, right, no. So a defibrillator is used to prevent cardiac arrest, right? So atrial fibrillation is or AFib is the arrhythmia from the top of the heart. And although the top of the heart, may be in AFib, it's not resulting in cardiac arrest. Blood is still moving to the rest of the body, and it's going to the brain, so you're able to survive with it. In emergent situations, do we have to shock someone before AFib? Yes, that's true. But a defibrillator, something that you live with, that's you wouldn't want to be shocked every time you went into AFib. You'd be very uncomfortable and very unhappy with me. Say, why did you implant this? However, for some people, we're unable to get them out of AFib. We're unable to keep them in regular rhythm, and we're unable to keep their heart rate in a controlled fashion. So in those cases, we may actually implant a pacemaker and then burn the electrical connection between the top and the bottom of the heart. That way you're dependent on the pacemaker to keep the heart going. And in certain patients, it actually leads to a tremendous improvement in their quality of life and their symptoms, and we were able to keep them out of the hospital.
Okay. Is atrial fibrillation hereditary?
Also a good question. There are some cases of AFib, and there's some types of AFib that have been shown to be hereditary, but for the most part, it really has more to do with your diet and lifestyle, and other risk factors. So you may have noticed there's many people on, there's kind of a recurring theme with a lot of our patients tend to have high blood pressure, they tend to have diabetes, obesity, sleep apnea. These are all significant risk factors for AFib, similar to the risk factors that you would think of for traditional heart disease. In the most part, AFib is not hereditary, and if it is, it generally tends to occur when you're younger. So for the most part, no, but rare cases there are.
Okay. Can you discuss any problems there may be with being on a blood thinner long term?
So, people will often ask me, okay, what's the main side effect of being on a blood thinner? It's really the main side effect is bleeding. Otherwise people tolerate it well. So we really have to look at what are the bleeding risks of being on a blood thinner long term. So if you tolerate blood thinners, you don't have bleeding from your GI tract, which is really the most common place that we see bleeding. Some people have slow bleeding, and they may need recurrent iron infusions or recurrent blood transfusions. Some people may have, a few episodes of very large volume bleeding where they have to go to the hospital immediately. Some people are unsteady on their feet and they may fall, they may hit their head, and they may have bleeding into their brain. That's a concern as well. So you have to assess the situation and see, how are people able to tolerate blood thinners and what are their bleeding risks. I think all of us feel that if you can tolerate blood thinners, it's probably the most effective way of preventing a stroke. However, if we're able to, in certain situations, treat you in a manner that we can get you off a blood thinner safely, or perform a watchman because being on a blood thinner is too risky, then we will pursue that. But ultimately, I think all of us agree that if you can tolerate blood thinners, you should remain on them.
Okay. Can you discuss treatment for tachycardia?
So tachycardia is a very broad term. All it means is fast heart rate. So tachycardia can be for multiple different causes. Many times we can try, and not all tachycardia is created equal. There's some tachycardia that's dangerous and can be life-threatening, and there's some and many times frequently seen tachycardia that's not life-threatening but can be really affect symptoms. So we'll often try medications, and if medications are ineffective, then we can, for most tachycardias, perform that procedure called catheter ablation, where we take catheters into the groin and cauterize the areas that are causing the fast arrhythmias to occur.
Okay. Can you discuss what the optimum blood pressure and heart rate readings would be for a non-diabetic 78-year-old?
So the heart rate, normal heart rate is between 60 to 100 beats per minute, and people will say, okay, is my heart rate too slow? And in the end, what matters more is how you feel with the heart rate rather than what the number is. Of course, if you're walking around with a heart rate of 30 beats per minute, that's probably too slow. And although it may not cause you to pass out or cause you to die, it may make you feel very uncomfortable. But normal heart rate is about 60 to 100. If it's a little bit lower and you're not feeling excessively tired, you're not short of breath, you don't feel that you're going to pass out, that's okay as well. In terms of optimal blood pressure, it's somewhat of a controversial topic because some people feel that as we get older, we should liberalize our blood pressure targets. So usually for patients over the age of 75, we may aim for a blood pressure goal of 140, because the worst thing that we would want is that if we keep you at a blood pressure of 110 and one day your blood pressure goes lower and then you were to pass out and break a hip or hit your head and something else. So we may tolerate a bit of a higher blood pressure. Usual blood pressure goals, I would say, is for the top number to be between about 120 and 140.
Okay, perfect. Yeah, I know that's sometimes subjective, so I was actually even curious for that answer. Can you talk about medications for AFib?
So the most important medication, as you've heard again and again, is the blood thinner. We want to make sure that you're not going to get a stroke. It's our biggest concern with AFib. We want to 100% prevent you from having a stroke because strokes, if you bleed on a blood thinner, we can give you blood. If you have a stroke, we can't give you brain. So all of us electrophysiologists and cardiologists are so concerned to make sure that you're on a blood thinner or have some means of preventing a stroke, because they can absolutely change your way of life. Aside from that, it really depends on what our strategy is for managing AFib. In some people, we decide that, okay, we're not going to try to get you out of AFib. We'll try to just, control the heart rate. And we can give medications to slow conduction through that gate between the top and the bottom of the heart. So some of those medications you may hear are beta blockers like metoprolol or carvedilol or atenolol. Some of them are calcium channel blockers like diltiazem or verapamil. In rare instances, we have to use medications like digoxin, but recently, over the past few years, we've tried to steer away from digoxin if possible. But there are cases where, digoxin is necessary and can be very helpful. The last class of medications are antiarrhythmic drugs. And these are special medications that help keep the heart in regular rhythm instead of just controlling how fast the heart goes. And those medications, we have to use them cautiously. Fortunately, we've learned so much about them over the past many years that we're able to use them more safely, and they can be a wonderful adjunct in some patients or even first-line therapy in some patients. But it really is patient dependent.
All right, looks like this is one of the last ones here as well. How long do these procedures in the electrophysiology lab typically take?
So it's pretty variable. I can tell you that I've done some procedures that last like 9 hours, but I think that's, fortunately, with our technology, that's becoming less and less often. The majority of our cases, let's say for implants, right, they usually take about 1 to 2 hours. For our ablation procedures, they usually take about 2 hours, more or less, depending on what we see. And if you're talking about AFib ablation, the amount of time it takes can vary. Sometimes it's as short as 90 minutes. Sometimes it's as long as 3-4 hours. And then in rare cases, like I just mentioned, it can be like 9 hours, but those are very select cases. But for the most part, I would say our implants take about 1 to 2 hours, and our ablations take about 2 to 3 hours.
Okay, great. And maybe lastly, you could just discuss how one might end up in an electrophysiology lab. So what that process is kind of like. Is it scheduled with an interventional cardiologist, or is it through the emergency department?
So it's a good question. It really depends on, what it is that's bringing you to the hospital, or to the office. So there's two routes. If you, let's say you were one of those unfortunate people that were feeling very short of breath, very dizzy, and you passed out, and you show up to the hospital and we find that your heart rate is really slow and you need a pacemaker. From there, we would take you from the ER, and I would see you, and we would bring you to either myself or one of my colleagues. We'd see you, and we'd bring you to the EP lab and do the pacemaker. Um, Similarly, let's say you were to come into the hospital and we found that you had a really fast arrhythmia that needed to be treated. Same thing, I would see you, would bring you to the hospital. The majority of our cases, fortunately, are elective, and in our field, we often make a joke that EP, which is short for electrophysiology, really stands for elective procedure. So the majority of the time, you'll see me in the office. We'll have time to discuss the options and come up with a plan of action. And then you'll come in electively into our pre-surgical area, into our cath lab area, go in, we get the procedure, and depending on what it is, I think the majority of the time, at least as we're starting out, you'll be staying overnight, but we're learning more and more how to get people home the same day.
Fantastic. Dr. Goyle, thank you so much for taking the time out of your busy schedule to be with us today. Very insightful presentation. Everybody who's joined us today, please just be aware you will be redirected to complete a survey, just letting us know how everything went today, how you enjoyed the presentation. We really appreciate all of your feedback. And thank you again for joining us today. Everybody enjoy the rest of your afternoon.
Thank you so much for having me.